Just wanted to say that. Thanks everybody for attending today. I want to give a disclosure that I'm not receiving any financial kickbacks from Dr. Stanley or Brown for giving this talk today. Also, I am not an expert at all. I'm a clinician, I'm a community organizer, and I really believe in the safety planning intervention tool. And when I believe in something, I get really passionate about it and I want to share it with everyone that I know. So that's why I'm here today. Last year, I participated in a training with Dr. Stanley on using the safety planning intervention tool. And I've worked in so many different levels of behavioral health care throughout my career: inpatient, outpatient, residential, community-based. And as you can imagine, so many of my clients were suicidal or had made suicide attempts. And when I did this training with Dr. Stanley, I realized that this intervention could be so powerful for the clinician and also for the client. So I decided to start a service improvement initiative with Chestnut Ridge Center, and Dr. LICSW was very generous in helping us with her expertise. COVID put that on pause for just a minute, but I really believe in it, and so that's why I'm presenting that to you. So while your goals for attending this Lunch and Learn might be to have one free CEU, or maybe to learn about SPI, my goal is to help social workers reduce their anxiety about working with a suicidal client, which will then help them empower the suicidal client to take charge of their own recovery. So, having said that, like any good social worker, I'm going to ask everybody to do a self-assessment. So in the chat box, if you could please answer this question. Here's the situation. My client expresses suicidal intent. My automatic thoughts are. All right, so let's get started, everybody. I just wanted to share with you some facts that I learned in a National Suicide Summit that was free and that was presented last month. Coronavirus and suicide prevalence. In the United States, suicide rates are at their highest since World War II. That to me was very sobering, because in the behavioral healthcare field, I feel like I already work with a lot of suicidal clients, and so to see this was really sobering. Factors that contribute to this increase are economic stress, social isolation, reduced access to religious services, and overall national anxiety. We don't know what's going on, we don't have a plan, we don't know what the plan is. And many different things are going on in our nation besides a pandemic. All right, so what is safety planning intervention? We're going to call it SPI. SPI is a clinical intervention that results in the development of a one-page document that clients can use when a suicidal crisis is emerging. This document can then be reused when future suicidal ideation returns. And it may be used to decrease future suicidal ideation and behaviors. So that's just a general overview. It was developed by Dr. Barbara Stanley and Dr. Gregory Brown. I have to give apologies to Dr. Brown. I cannot find a good headshot of him on the internet. So here we have a picture of Dr. Stanley. So that's why we call it the Stanley Brown SPI. All right, so why should we use the Stanley Brown SPI? We want to use it because it uses evidence-based risk reduction strategies. It's very important that we use an evidence-based suicide risk assessment. It's very important that we use an evidence-based risk reduction strategy so that we're all using the same language as clinicians when we're talking with clients and their families, and when we're talking with each other about clients and their plans. We need to make sure that we're using a tool that is standardized and has been validated. So your agency might have its own sort of homegrown safety planning tool, or you might have found one in a social worker's Bible that you might copy and distribute to your clients. But what we're really asking is that you start using the Stanley Brown SPI because it is evidence-based, it's standardized, it's validated, and then we're all using the same language. So using the SPI may reduce further suicidal behavior, and we'll talk a little bit more about that in a minute. It's unique in that it's systematic and comprehensive. It can be used in the context of a trip to the emergency department, ongoing outpatient treatment, or inpatient care. So you can use it at any point that you might work with a client, no matter what agency you work for. And it is recommended as best practice by Suicide Prevention Resource Center. It's the gold standard. So here, just wanted to show you a graphic of best practices for comprehensive suicide prevention framework. As you can see, there are many different ways that we can support our clients in recovering from chronic suicidal ideation, assisting them and moving towards recovery, such as promoting social networks and connections. We identify people at risk, and we do that with a evidence-based suicide risk assessment tool. We're going to encourage our clients to increase their help seeking. We are going to provide increased access to mental health services. With the client, in a collaborative way, we're going to establish crisis management and prevention procedures, and that's what the SPI is. We're going to restrict access to lethal means, and we're also going to enhance their life skills. I'm going to take a deep breath and ask if anyone has questions. All right, moving on. So here is an example of the safety plan. We're going to go through this in detail, so don't feel like you need to memorize it. But as you can see, it's a one-page document, and everything is written out so that you remember what you're supposed to ask, the client remembers what they're supposed to be focusing on, and it goes through in steps. It's just a simple one-page document. It's not copyrighted. This is free. You don't need any special certification in order to begin to use the SPI with your clients. As someone who works for a community behavioral health care center, where we have not a lot of funding for education and trainings, I really like that. Free training is great. All right, so how do we implement the SPI? You're going to do this with the client following either a comprehensive suicide risk assessment, or let's say they are hospitalized on an inpatient psychiatric unit for suicidal ideation, and you're preparing them for discharge. So this would be a part of their discharge plan. It is very important that you develop it collaboratively with the client. Let me say it again, collaboratively with the client. You want to make sure that the client is fully bought into everything in their plan, because they're the ones that are going to have to do it. And we also want to empower them to know that they can be change agents in their own lives. Additionally, if you do it for the client, let's say before they leave from an inpatient unit, I'll just go ahead and be fully transparent. I have worked on an inpatient psychiatric unit as a social worker. I was, part of my process was to give the client their safety plan before they were discharged. Usually we were slammed with lots of different clients. We had groups to do, family sessions, intake, psychosocials, all of the paperwork, all of the progress notes. And then the safety plan was unfortunately pushed to the very end of their stay. And I would look down and I would say, oh, whoops, we've got to get the safety plan done before you go home. I would hand it to the client. And what usually happens is the client doesn't want to do it. They want to leave. They want to be discharged. They're hurrying, they're packing, and they haven't really thought about it that much. And so then they give it back to me and they say, well, I learned, 2 coping skills in group, and one of them was to do yoga. And the other one was to eat healthy. And then they just give it back to me, and it's like something that they think I want to hear. I guess that's what I'm trying to say. You don't want the safety plan to be something that the client is doing to get you off their back. The safety plan has to be something that really works for them. Does yoga work for everyone? No. Is healthy eating going to be a part of everybody's toolbox of coping skills? No. So you have to actually sit down and do it with the client. I'll get off my soapbox about that. It can take about 20 to 45 minutes to complete if you're doing it really comprehensively. And also, I know as social workers that gives you a little bit of pause because, like I said, we're already really busy. But if you really take the time to do this, that will pay off in the end because it can reduce the number of rehospitalizations. It can reduce the number of times the client's going to call you on your administrator on call phone in the middle of the night. So it's really important to do the work in the beginning. You're going to do the SPI with the client and you make a copy. You put 1 copy in the chart and then you give the original to the client and you ask them to put it in a visible place where they'll be able to see it. Some people shrink it down and laminate it so they can put it in their wallet or their purses. Wherever it is that the client can refer to it in times of crisis are really helpful. Okay. So an overview of the SPI is that it is a written list of coping strategies and resources for the client to use during their suicidal crisis. It helps the client have a sense of control. They feel like they will have a sense of control over their suicidal crisis. It uses the client's own words. It can be used as a single session intervention, or you can use it in ongoing treatment. And that's one thing that I really, really like. So a lot of folks come to the emergency department with suicidal ideation. They don't get admitted to the hospital. The psychiatrist does an assessment and says, I think you're low risk. I'm not going to admit you. I want you to come back to clinic in 2 weeks and see a therapist. So many people never come back. If they had the opportunity to have someone go through the SPI with them, that could be incredibly powerful for them if they never went back to clinic to see an outpatient therapist or psychiatrist. So that's another reason why I really like the SPI. What it is not. So it's not a substitute for individual psychotherapy. When I say it can be used as a standalone treatment, I don't mean that it can be used instead of psychotherapy. What I mean is if the client never decides to enter into psychotherapy, having that SPI will still be powerful for them. It's not for use with an individual who's in imminent danger of attempting suicide. So if someone can't contract for safety and you need to get them hospitalized as soon as possible, then you're not going to be doing the SPI at that time. You would wait until they've been stabilized in the hospital and then you would discuss it with them. And it is definitely not a no suicide contract. Raise your hands if you guys are still using no suicide contracts. Totally be honest, this is a safe space. All right, awesome, good. Nobody's using them, so that's great. Don't use them anymore. I could say a little bit more about that, but I have a lot of slides here and it's already 12:24, so I'm not going to go into it. But if you want to talk more about why we shouldn't use no suicide contracts, then just drop me an email and we'll chat. Okay, one thing that I really liked about Dr. Stanley's training last year is that she helped us to understand the suicide risk curve. When we understand it, then we can help our clients understand it, and then we can help empower them to know that if they use coping skills during their highest risk, those feelings are going to come down. So suicide risk fluctuates over time. You might have clients who have baseline suicidal ideation, but their level of risk of actually acting on those thoughts is pretty low. What we're talking about here are clients who don't have suicidal thoughts, or maybe they do have suicidal ideation, but with no intent on acting on them. And then life happens, they have triggers, they have setbacks in their treatment, and then those thoughts become more and more persistent and their risk becomes higher. At that point, at the top of the curve, that's when they're at the most danger of acting on their suicidal feelings. If you can help them to learn how to be safe during this time, but to remember that it's going to fluctuate and eventually it's going to come back down, then that helps empower them to get through that crisis. Does anybody have questions? So really, you're letting the clients know that they are in charge of their own recovery. They're in charge of their own treatment. They're in charge of their own behaviors. Suicidal thoughts are not in charge of them. If you reduce risk during the highest peak and you help them ride that wave, then they'll come back to safety. All right, so the clinician is going to, when you sit down with a client and do the SPI, you're going to ask them for a description of the recent suicidal crisis. So you're going to ask them what events precipitated those thoughts or those plans or that action. And you're going to ask for a pretty thorough description. You're going to review the suicidal risk curve with the individual. And you're going to talk to them about why it's important to do the safety plan intervention. You're going to describe the development of the safety plan as a collaborative process. I think that's really important to let clients know why it's important for them to take charge of their own recovery. And let them know that you're not the expert in their recovery. They are the experts in their recovery. You're going to explain how to follow the steps of the safety plan. And then you're going to talk about where they're going to store the safety plan, who they're going to share the safety plan with, where they might have pitfalls for following the safety plan, and how likely they're going to use the safety plan. So I'm going to go through this pretty quickly because then it's in more detail in a few more slides. The components of the SPI are helping the client recognize the warning signs that they're entering a suicidal crisis. You're going to help the client learn how to employ internal coping strategies. You're going to help them identify social contacts they can use as a distraction, identify family members and friends who can help, which mental health professionals they can call. You're going to discuss the use of lethal means. You're going to reduce the potential. And then this is an option for Dr. Stanley. She said, if you like to, you can discuss reason for living. It's not necessary. A lot of folks can recover from a suicidal crisis without being able to identify a reason for living. So we don't want you to get hung up on that, if that makes sense. So warning signs, the very first part of the SPI, you're going to ask your client what was occurring from the beginning of that experience to when you had the suicidal thoughts or extreme distress. What were you thinking? What were you feeling? What were you doing? How did you feel in your body? Avoid using external cues like I had a fight with my boyfriend. So I know clients are quick to go towards external cues for triggers, but we really want to try and guide them back to internal. thoughts, emotions, behaviors, physical sensations. So for internal coping strategies, it's really useful for clients to attempt to cope on their own with their thoughts, even if only briefly, because that enhances their self-efficacy. That reminds them that they are experts in their own recovery. And again, I can't remember who said thank you for the AOC shout out. It helps them to remember that they don't have to call the administrator on call. They don't have to call, they don't have to go to the emergency department every single time they have a fleeting thought. What you want them to do is attempt to cope on their own, even if only briefly. And then you help them build mastery. So sort of like Marsha Linehan's DBT, building mastery. If you are able to do something for 5 minutes and you're successful, then maybe the next time you can do it for 10 minutes and so on and so forth. It gives the client the sense that suicidal thoughts can be mastered. And clinicians use a problem-solving approach to ensure that potential roadblocks are identified. Okay, then the next section after internal coping strategies, you're going to talk with the client about how socialization can benefit their mental health. And so what's really important with the SPI is that you're going to teach the client, always go to the first step first. If it works and you're not having those suicidal thoughts anymore and you feel like you've returned to safety, then you can stop. If you do the first step and it wasn't helpful at all, then go to the next step. So it's sort of prescribed in that way. You don't have to stay in a certain step for a particular amount of length of time, but you do want to ask the clients to move through the plan step by step. So for socialization, you're going to talk to the client and you're going to say, if you can't get out of your own brain, you can't get out of that negative loop of thinking, and you're still having those suicidal thoughts, then I encourage you to go to the next step, which is socialization. And the crisis might be alleviated if the clients are feeling more connected with others or a sense of belonging. So let's think of this pre-COVID. You might encourage them to go to coffee shops, places of worship, AA meetings, maybe the mall, again, pre-COVID. Anywhere where they're going to be seeing other people and distracting themselves from thoughts and worries. This is not a specific place for them to actually seek help. So you want to be really clear with your client. You don't want them to go to an AA meeting and announce to the entire group, I'm feeling suicidal and that's why I'm here. You're not going to ask them to do that. What you want them to do is consider how being with others can help them feel connected and help distract them from their thoughts and worries. Now, during COVID, this has been incredibly difficult, and we already talked about it in the beginning of this talk, that people are feeling isolated because they don't have the normal opportunities for connectedness. And we've been encouraging our clients to participate in as many Zooms as possible. Get out to the park, wear a face mask, any creative way that you can socially distance and stay safe, but also connect with people. So the next step, if the client goes to a public place, or let's say they can't get to a public place. So that's really the answer there. During times of COVID, if they can't safely get to a place where they could distract themselves, then they should go to the next step immediately and they should ask their social contacts for help. And so this is where you'd have them identify safe family members or friends that they can trust during that crisis. And they would directly ask for help or support. They would say, Mom, Dad, best friend, I am feeling really unsafe and I've tried these other things that are in my safety plan and it's not helping me and I need your help. During this part, you want to ask them who's the best person to involve and also ask them to consider if there are any cons of involving this particular person Say, for example, if they're going through a divorce, would their ex-husband be the safest person? Maybe not, maybe so. If they're a 15-year-old and they are having trouble with their parents, you want to ask them to figure out, well, maybe who's the safest person in your life that can help you with this. All right, so in the next section, you're going to have them list the clinicians' names and phone numbers, the suicide hotline, crisis text line, and you also want to discuss with them what they can expect when they call these clinicians and these phone numbers. I think that's really important. I work for a large agency that has a very complicated phone tree, and I know even on my best day, when I call and try and reach someone, if I have to press too many buttons too many times, I get frustrated. So consider if your client is in a crisis and they have to press too many buttons, how much worse that's going to make them feel. So I like to tell them ahead of time, hey, if you want to talk to me, my business hours are 8 to 4:30. If you want to reach me directly, press X and go to this. If you need to reach someone after 4:30, this is the other phone number to call. If you try to call me, give me 24 hours to respond. You want to be as detailed as possible so that you're not going to increase the frustration in your client should they not be able to reach someone right away. All right, means restriction. This is really, really important. Really important. Even if your client has not stated they have a specific suicide plan, even if they say they are passively suicidal and they've never said that they have an active plan, you must talk about means restriction. Because remember, if we're looking at the curve, your ability to problem solve is at its lowest when you're at the highest risk. And so if you have access to lots of different means to harm yourself, you're not going to be able to problem solve as effectively and say, no, that's not a good idea. You're going to collaboratively identify ways to secure or limit access with the client. So you might say, what are some means that you have access to that could potentially hurt you or end your life? And they might say, well, my husband has a gun. Okay, let's talk together with your husband or with your safe family member or friend. How can we secure or limit your access? And you want to also talk about length of time. You know, obviously we're in West Virginia, we have a lot of hunters. People get really defensive and guarded when you start to talk about restricting access to their guns when there's a mental health crisis. However, it's important, but you can say with them, when you've reached a more stable period in your life, then let's talk about regaining access to your guns. But for right now, we're going to ask that you go to therapy, take your medication, see your psychiatrist, and let's reevaluate with your psychiatrist at the end of a month, 6 months, whatever it is. But you really need to talk about that length of time and give the client specific things that you want to see them participate in order to sort of regain stability. I also want to be really clear and say it's important not to stereotype your clients and think that you don't have to talk about guns just because of their age, their gender, or their physical presentation. Do not assume that an 88-year-old Caucasian female wouldn't attempt to end her life with a gun. Don't assume anything. You have to ask. Don't be afraid to ask. I empower you to ask. Any questions about that? All right, moving on. So I think I said a little bit earlier when I was talking about working on an inpatient psychiatric unit that safety plans are often of poor quality when they are not done collaboratively. Individuals have reported that their plans are more helpful when they're done with the clinician. And when you have a higher quality plan, you have fewer psychiatric hospitalizations, which we know that's the goal. Psychiatric hospitalizations are, for someone who is only suicidal, psychiatric hospitalizations are not the gold standard for someone who is purely suicidal. If they can be safely managed in an outpatient setting in their home with a really good safety plan and really good outpatient therapists and psychiatrists, then that's the best place for them to be. This safety plan, I think what I forgot to say is it's really important that all members of your client's care team know about the safety plan so that they can also refer back to it. So let's say I have a client who has a safety plan and I'm her therapist and she has a psychiatrist in a different clinic in a different county, which we know this is West Virginia, so that really could happen. So I want to say to my client, Susie Q, I really want you to share the safety plan with Dr. Jones. And it's important that we all know and we can refer back to it and help you remember to use your safety plan. So then best practice would be for Susie Q to go see Dr. Jones and for him to say, Susie Q, it's really good to see you. I see in your chart that you have a safety plan. How is that working for you? And she might say, you know what, Dr. Jones, when I was working with Beth, we thought that this X, Y, and Z was going to help, and it really wasn't. It wasn't helpful to me at all. Then Dr. Jones and Susie Q would revise the safety plan and they would update it as the client's life changes. All right, some feedback from clients who have actually used SPI are 100% recalled completing the plan, 97% were satisfied with the plan, 88% could identify its current location and where it was kept, and 61% reported using it. This is from a study, I'm sorry, I should have said, a study with veterans that Dr. Stanley and Brown conducted, and links to that study are in other slides down at the end. The most helpful aspects of the plan were social contacts and distractions, closely followed by social support and contacting professionals. Use of the internal coping strategies did not get as high of a rating, but we all know that that's the really hard stuff, is changing how you think about things. All right, it's already 12:51. Wow! I have included 3 videos that you can find on Vimeo online, just showing you how a clinician might talk to the client about the safety planning. It's in 3 parts. They're really, really short. I would encourage you all, if you're interested and you think you want to incorporate into this into your practice, please go watch these really short, good videos. They are actually put on by Joint Commission. I've also included some safety planning apps that your clients can use on their smartphone. We have the My3, and then the safety planning guide. That's 5 steps. All right, any questions?